My name is Dr. Thormann. I am a neuroradiologist at the University of Magdeburg in Germany. The main issue for the radiologist, if we look at stroke imaging, is that we have to do the stroke imaging quick. To identify a patient with a stroke, you have to identify the occlusion if there is one, and you have to transport the patient quite quickly into the angiography suite should there be a thrombectomy. Another issue that we have in oncology imaging is that after the patient has been treated, to interpret the different changes in the MR imaging, if the tumor reoccurs, or if it's a radiation necrosis, or if it's actually a progression of the tumor. When we looked at perfusion in the past, we only knew what went into the microvessels and what came out of it. So a lot of the information that occurs within the microvasculature actually gets lost. We were quite intrigued by the vascular model that Cercare has because they are able to show us the heterogeneity of the flow within the microvasculature and provide additional information on that. We have made the experience then when using the Cercare maps, so both the standard maps and the advanced maps. Our results or the reports that we do on the imaging become more robust. We can reproduce the results easily. There are no differences in the results. The readout is the same no matter what workstation or what CT scanner or MR scanner we actually use. We have completely automatized that process, right? So you have only the radiologist in his reading room, and the results or the images get sent to the workstation automatically. The post-processing is done automatically, and then the images or the results get sent back to PACS. For example, in stroke imaging, there's OEF, so oxygen extraction fraction. That is very sensitive to changes in the cortical areas in stroke. And we also know that the CMRO2 map in stroke actually is a good indicator of the infarct core at a later stage. So we are now quite more confident to predict the infarct core that we were when just using CBF and CBV. To detect early tumor recurrence and high-grade gliomas, and we are actually now able to see in many instances the tumor recurrence earlier than we used to when just using CBV alone. So the three main benefits for us when using Cercare in clinical routine are more confidence in our results, superior robustness of our results, and in patient cases where we detect early tumor recurrence, better treatment and hopefully better patient outcome. So my advice to anybody who installs Cercare and uses it for both stroke and oncological imaging is to not only stick to the maps that we are used to in perfusion imaging like CBV and CBF, but also dive into the information that the advanced maps actually can provide.